Welcome to A Deadly Silence. I'm your host, Larry Curtis, and it's the goal of all of us associated with our program to bring you current and educational information surrounding the alcohol and drug epidemic, not only here in the city of Brockton, but throughout all of our South Shore communities. Today's guest is Dr. Kenneth Lawson. Dr. Lawson is the Chief of Emergency Medicine at Signature Healthcare Brockton Hospital and has been involved in emergency medicine for well over 25 years, it looks like, Dr. Lawson.
Great. Thank you for having me.
Welcome to our show. Thank you very much. What I'd like to try to do here this afternoon is basically kind of have you walk us through the process of an addict's admission to an emergency room due to a overdose in that process. So, typically what we hear out there is that there might be two ways that a person might be received at the emergency room. It may be through emergency medicine, EMS services, local cities and town, ambulance, fire department, or it could be a private family member or friend dropping somebody off at the front door. So tell us kind of what happens when the staff is confronted with an overdose.
I'll lead you through that. The emergency department is, I think most people are familiar with it, a very big, busy place. A lot is going on at all times. At almost any given point of the day or night, we have ambulances coming and going, people coming and going through the lobby and the waiting room. We get our drug overdoses really in two fashions and about even. How much are being brought in by EMS, in by the community, ambulance 911 calls. That run is a little easier for us. We know someone's coming ahead of time. EMS will pick somebody up. Typically now, which is something relatively new in the last year, they're giving a lot of nasal Narcan in the fields, giving IM or IV Narcan as needed, and starting the resuscitation to bring somebody back. We'll typically get a call ahead of time, either a minute out, up to 5 or 10 minutes out, depending on which town they're coming from or which area of the city they're coming from.
Let's pull back for a second because obviously early in 2014, Governor Deval Patrick at the time declared the opiate epidemic a public health crisis. And through that process, there was a major push on the part of first responders, fire, public safety, and police to basically introduce Narcan into the community, where previously it was on a trial basis. Have we seen an influx of patients now coming in as a result of that drug now being available through emergency services?
That program is really interesting. The state ran a pilot. The pilot was successful. And then honestly, I think it was stalled getting out there. And what we found with, if people remember back a year and a half ago, just a run on unfortunate, tragic deaths from heroin overdoses over and over and over again. With that, here at Brockton, a bunch of the people got together and decided, this is kind of enough's enough. We had a major push on teaching in the different areas. We hit, I'll probably get the names wrong, but Middlesex, Plymouth County, Bristol County, down the Cape. Yeah. And those counties were all trained on how to use it, mainly by one of the physicians from Signature Healthcare. Dr. Muse was very instrumental in rolling this out to the pre-hospital group, but we provided medical oversight and training and the initial prescriptions to get people up and running with nasal Narcan. So we went from almost no usage pre-hospital to right now, today we're up to 80% of the cases being brought in are receiving nasal Narcan, and not just by pre-hospital personnel, but it's prompted, I think, the public to gain a tremendous awareness on using it. So families, friends, everyone seems to have it now.
Family and loved ones of the addict who, through the educational process, have learned through organizations such as the BAMSI here in Brockton, the Mayor's Office of Opioid Prevention, that, in Learn to Cope, one of the, real organizations that was piloting that program back 3 years ago, so that Narcan is available. And
Narcan's been a huge success. It saved countless lives. It really has. So if we get back to the ambulance coming in, so people in the house, loved one may have already administered Narcan. If not, EMS or police, whoever's there first, can administer Narcan. Nasal Narcan takes a little while to take effect. It's not instantaneous. It takes some time, so usually we'll have 911 called as well, and the patients are brought in. So if we get the warning in the emergency department, we know an ambulance is coming, we know if somebody's responded or not prior to them arriving. We know someone's coming back out of it, which is great. We also know if someone's not coming out of it, if they're going into cardiac arrest, respiratory arrest, or something else that needs to happen. So based on what we know from the EMS crews giving us that heads up, we'll prepare the rooms of what we need. Now, if someone obviously is in distress, they're going to come into the major resuscitation rooms, and there'll be a whole team to do everything you possibly can to bring somebody back. If somebody's fortunate enough to have already received nasal Narcan and they're responding well, they'll come in, and honestly, hopefully we'll have a room available. If we don't, you'll be sitting right in front of my workstation or one of the other doctors' workstations to be followed. The process when you come in the door, then typically, depending on the response and depending on how well someone's doing and other factors that we look at, you may run the range from just being put on the cardiac and oxygen monitors to IVs, fluids, labs, lines, repeat doses of Narcan. Now, anyone that comes in having received Narcan, particularly the EMS route, you're guaranteed to be watched in an emergency department for a set amount of time. And this is key because people get really pretty touchy about that. Family gets touchy about that. If you've ever had experience, someone may go from really on the edge of death. After they receive Narcan, they're breathing well, they look good, they're feeling good, they are back to their baseline, maybe queasy, a little sick from that. But at that point, they're very agitated and want to get out of there.
Now,
and that's a touchy point.
It's a kind of combination of the desire to get back the high or that euphoria feeling from the opioid that they've ingested versus the Narcan blocking that.
Right.
And like, why did you do this to me?
Exactly. It's that combination. So people really want to get out of there.
Yeah.
And you can understand that. We will not let you leave. Okay, we have to watch people, and it's a trick on this one that if someone takes heroin or any of the opiates that are out there, they stay in your body for varying amounts of time. Narcan is very short-acting, and the fear is that you give someone Narcan, they respond, they're breathing well, they leave. The Narcan wears off, the opiate, whatever is still in their system,
is still there,
kicks back in,
right,
knocks the respiratory rate down, and they die. And that's the danger. So when patients come in, typically you're going to be watched 3, 4, 5 hours, depending on how much Narcan you've been given and how well you're responding. And that's if everything goes perfectly.
So one of the important aspects that I'm hearing is that if you happen to be a parent or a loved one, you come over a family member that might be overdosed and you have Narcan, you administer it, you really need to get 911 response and get you to an emergency room to be followed up immediately.
That's critical.
Again, because I think sometimes there's an impression out there, like you had mentioned, that the Narcan is in effect, the patient is cognizant of their whereabouts, they're agitated certainly,
right.
So maybe there's not as much attention being paid to the after effects.
Exactly,
Yeah.
and that is the big risk. My thought, I think everyone's thought, is that if you're going to administer Narcan, you should call 911 and have them brought in and observed and watched. That puts the patient into the safest category, and that's what everybody's after.
Now, one of the kind of the catch-22s that have been out there is that there's the Good Samaritan law that people need to be aware of out there. And particularly, if you're in a party setting, you have college kids at the dorms, or you're at a house party because your parents might be away for the weekend, somebody's throwing a house party, and somebody overdoses, and obviously there's a collection of different opinions as to what should be done, Ultimately, somebody's probably going to do the right thing and pick up the phone and call 911.
We hope.
Well, we want to make sure the message is that somebody has to do that.
Exactly.
You need to let your kids know that you need to really do this. And the Good Samaritan law, as I understand it, basically allows someone to notify emergency services that an individual stopped breathing, and that's the preference of language I understand is to be used. Somebody stopped breathing, send help right away, versus somebody has taken illegal substances and is overdosed, because that in turn also involves the police follow-up as well. But the Good Samaritan law basically is that you can make that call, and even if you're in the presence of that individual, so long as you do not have any outstanding warrants or there isn't enough, there's a small amount of drugs in place so as not to be perceived as dealing.
Exactly.
That there'll be no, repercussions on the part of law enforcement.
Right. It's exactly it. The message we want out there is just call, okay? They're not out looking for you. They're out trying to just get that person in and taken care of. And that ties into how many patients are just dropped off. It's the drive-by, and we get a lot of that. Cars honk their horn, and somebody is pushed out the door.
Wow.
In front of the emergency department, and it happens quite frequently. Mm-hmm. It's not an everyday event. Is it an every week event? Yeah, probably. Mm-hmm. And that's risky. That's dangerous. There's no need to do that. You could actually stop and allow us to help get the person out. It saved them time. Mm-hmm.
As well as probably provide some valuable information as to what may have taken place.
Absolutely, absolutely.
Yeah,
The fear at parties are that people get so out of it that they get pushed off to the corner.
Correct. Mm-hmm.
Or outside in case they get sick.
Mm-hmm.
And then no one checks on them again. Nobody makes the call, and those are the ones that bad things happen to.
And then because the opioids have begun to shut down the respiratory system and the breathing and issues, and nobody's paying attention, and the next thing you know...
So you drift away, you stop breathing, or you have other things in your system. Mm-hmm. You may have vomiting, et cetera.
Okay. So we're in the emergency room setting now. You're evaluating, as you mentioned, the level of care required, for that particular overdose individual, and those that you say may be able to sit in a room and be watched and monitored and basically cared for. That's the lower risk, I guess, level, case level, versus the one that you may have some breathing issues that you may have to deal with. How does let's say it's a child under the age of 18.
Right.
Do you notify the parents?
Absolutely.
Okay.
Ideally, yes, we'll find out. We'll have somebody that's under the age. That's not a problem. We will track down parents, family members, whatever we can do to get them in as soon as you can. Obviously, the doctor's more attuned to the patient and doing anything possible to bring them back. But yes, we have staff that'll start to pursue family members, et cetera. Yeah. We get a lot of that from EMS. We get a lot of that from police if they're involved. They help us with that component of it. The hardest part is if you get somebody that has no ID, no connection, somebody drops them off. Literally, the drive-by 17-year-old with almost nothing in their pocket. Yes, it takes a while to find that out. But you really need family there. You desperately need family there. I can only imagine being a parent of that age group at that time and not understanding that or not hearing about it would be tragic. So that's easy. The trick comes down to now that you're 18, you're an adult, we're limited in what we can do.
HIPAA privacy laws come into effect.
And that's tricky because I think in everyone's core we would like to let everyone know and try to get somebody as much help and let family be involved with all of that stuff, but we can't.
Right.
If we have someone that's completely unconscious, unresponsive, then yes, we're obligated to contact the next of kin. But if we have someone that comes back and is awake and alert and talking and making sense, and they specifically do not let us contact family, we can't. And that's very hard to do. It's very hard for the staff, but we have to sort of abide by people's wishes on that. Again, as a parent, that's horrible. Because you can imagine the 19-year-old who's not going to let you inform anyone that they know, anyone in their family. And here's this great opportunity we have in front of us to try to make an intervention or get them into the right setting to help them out, and you can't. And you know it's going to be missed. And despite counseling, despite information, despite everything that we can do, we worry about losing that patient and then having them come back.
There's probably a catch-22 in here somehow.
Yes.
Because when you get into insurance coverages and the information that you need to obviously process this through, 19-year-old kid is probably under mom and dad's health insurance
Right.
policy.
So exactly what happens would be a month later, the bill arrives and somebody
Okay.
goes, why were they in your emergency department? What was going on here?
Uh-huh.
And then, you know what? If that's
It
you,
hits the fan.
I can't help you on that one. That's
Okay.
that's between you and your family, and you're
Okay.
caught.
All right. So,
And
you know,
I honestly think that's probably a great thing.
and that's important for kids to understand that, you know, you're not going to hide it from mom and dad.
Right, right.
In the
No, they're
end.
going to find out.
Yeah,
It's just
right.
a question of
They're going to find that out, right.
how would you like them to find out?
Okay. So let's talk about the coherent, patient that's in there now, who has become agitated because basically Narcan's been administered, the high has been removed,
Yep.
but they're still at risk because of the opioids that are still in the system, and Narcan's going to wear off. What takes place in that process in relationship to trying to get through to the patient what they're dealing with and what they need to be looking for?
So what ends up happening typically, it's multiple layers. Okay? When somebody initially comes out of something, there's a lot of denial, there's a lot of just sort of other emotions that go on. People just kind of refuse to believe that they're there, and they want to get up and leave. And I think at some level, losing that right to leave is step number one, understanding that you have to stay for a certain amount of time, and you are not in control of that. We are in control of that. We have to keep you there.
You're legally obligated.
Yes.
To that specified.
And we'll
period
have
of
a
time.
sitter. We'll have the means to keep you there, to keep you safe. We're obligated to keep you safe.
Mm-hmm.
And so that's step one. And most people get that. They understand that we have to do this. We have to put them into as safe as we can possibly be.
Right.
Now, over the time of your stay, there's a lot of time there. We have about a 4-hour window. And what ends up happening is, yes, you're going to get re-seen again by the nurse who's going to talk you through that story. You're going to get re-seen by the doctor who's going to go through that story with you. You may get seen by our social workers. You may get seen by some of our behavioral health counselors. It depends on what resources we can bring to bear. Now, honestly, there's not enough resources out there. We don't have someone 24/7 who's capable to really sit down and go through this.
Right.
That would be wonderful.
Mm-hmm.
We don't have that means. So you do the best you can, and you play it a little bit off how well someone responds to you. You have to make that connection. Early on in the stay, they get information on that. We have really nice, very concise handouts with information,
Okay,
with
so-
resources to go to
Okay, mhm.
that people can start to look at. You can start to make phone calls if you want to try to get assistance lined up ahead of time. But you get that at half-hour point, an hour point, at the 2-hour point. Before you go home, all of that gets reviewed again. Usually there's a bit of a heart-to-heart talk, because there's some people that know what happened to them. A lot of people really don't. And we see a lot of first, second, third-time users that get into big trouble with these because they've not figured it out. And that's really a very, very dangerous time for people having a serious overdose or killing themselves accidentally. And you try to make that connection before they go.
Mm-hmm.
Honestly, there's just not enough time to do it the way you'd prefer to do it, but you give it the time that you have based on whatever else is going on in a big, busy place.
Is there a need to maybe administer additional medication during that period of time for that particular patient that is coherent? Or
There may be, but not usually Narcan.
okay,
Most of the time we don't need to.
okay.
But if we leave you on an oxygen monitor, we can really nice control of your respiratory rate, and things like that, and how much oxygen you're pushing
Yeah.
to see what people do. It depends what else is going on.
Yeah. What are the types of effects of the more critical patient that comes in, that has gone into respiratory
Right.
distress? What happens in that case?
So the big thing there is when somebody has an overdose of opiates, your respiratory rate drops, your oxygenation is dropping, your brain's not receiving enough oxygen, and you start to have hypoxic brain injury. What you'll do is become hypoxic and pass out. Or at this point, you're pretty much out of it from the opiates. But you start to have brain damage. At the same time, you're not oxygenating the rest of your body, you will go into cardiac arrest after the respiratory arrest. Now, If we're deep into that process, we may have somebody that's brought in, they've been given Narcan, there's no effect.
Okay.
We're pretty far along on this one. CPR will be initiated in the field. They may be intubated in the field or in the emergency department. Putting a tube down to breathe for them, put on oxygen, we'll take over the control of breathing. We'll do whatever it takes to get the heart going again in the hope that we can resuscitate the brain.
Okay.
A lot of times early on, you don't know what's going on. We don't know if we're going to be successful until hours later, possibly even days later. And that's just a horrible, horrible time for anybody involved with this, because we may get the heart back, but not get the brain back. And what a terrible spot to be in. Now, anytime anybody's doing an overdose, to get down that close, you're right on the edge of knocking off parts of your brain, of taking out the easy areas, essentially there, the watershed areas of the brain. Are you going to recover completely? Probably not. But we have a lot of brain cells. We're banking on that for that. So it's a tragedy. It really is a tragedy.
And over the course of the years you've been in emergency medicine, you've seen the different recovery cases that have taken place, I guess, where some have made full recovery, others maybe not. I know that we were talking with the family from Taunton a couple of months ago, where their son experienced the same situation, went into the hospital, had some brain damage. He's alive and well today, but obviously, the athlete that he was during his high school, college years is not there today.
Right, and you see that a lot. It's a tragedy, but people come back essentially 100%. We have people that come back in essentially a vegetative state. They're unable to do anything. They're unable to care for themselves. And they're otherwise young and healthy. Their heart keeps beating. They're going to probably have a long life in front of them in a nursing home setting at a young age, which is tragic. And we have all the range in between. We have some that don't make it. I mean, we do have a fair number of opiate-related deaths, and it's terrible.
Now, you had mentioned earlier in the conversation there are spurts of excessive overdoses that take place, and that seems to be depending upon the potency of the drug that might be out there at a certain time. We know we saw it here in Brockton back in, I think it was January, February 2014. Taunton had it, the same time going on over there. Are you alert, as an emergency, as a hospital, are you made aware of when that potential potency is out there from, law enforcement or things of that nature?
We don't find out from law enforcement. We find out mainly from sort of the indirect evidence of a bump in the number of patients coming in. This past December, we almost doubled the number coming in. So we're heading into the holidays, and probably whatever the heroin that's coming through was either being cut with something a little bit stronger or different, with either strychnine or fentanyl or something along those lines, or just the batch coming through is that much stronger. But for us to go along at a steady rate and then double the number of overdoses in a short 30-day time period is staggering. I don't think people quite realize that you can use the same supplier, the same everything, the same amount of the drug 3 times in a row, and somebody gets high, and the 4th time the exact same amount kills them. That's the problem with this. There's really, you hate to say it, but in business, there's no quality control here.
Correct.
The strength varies, and that variation is what goes on to kill people. It's the same amount over and over, and that time it's death, and that's terrible.
Statistically, I think it's said that, most addicts who become addicted, potentially maybe 65-70% of them are becoming addicted through prescription pain medication. They had an injury, they were prescribed a particular, pain medication to help in their recovery, and ultimately in the end, an addiction has taken place, and they go outside to start looking for pills or ultimately, getting the addicted to the heroin aspect of it. What's happening in the case of emergency doctors? I'll use the term carefully, pill pushing in the ER.
Right.
Pharmaceutical companies obviously want to, get their product into the market as great as they can. You hear stories of, some physicians pushing a prescription on a patient who may say, no, I don't want to do with it. And what's happening in that arena?
At least in our area, those days are long gone.
Okay.
It comes down to this. There's a lot of narcotic limitations being set. And when people come in with whatever the injury, if you break your leg, you may have a significant amount of pain and you want to give some pain medicine. But the days of getting 30 tablets or 40 tablets are long gone. We set limits, and the limits get less and less and less. You're looking at no more than about a 2-day window for something, even for a serious injury.
Okay.
For that. So now we've gone to the route of rather than giving a lot for any particular reason, rather we get complaints that we're not giving enough over and over and over. And what you'll find, at least in our emergency department, that number just keeps creeping downward.
Okay.
And patients respond very well to it. I think the downside is, in order to get more than about a day and a half, 2 days worth, they're going to have to contact their primary care physician and get it elsewhere. And that's what you need to do. You need to, at some level, put some barriers to it, make it a little bit harder, and make people stop and think about that. Now, drug companies have no impact. They're not allowed in, at least in our emergency department. We haven't seen one in years. They're not allowed in anymore.
Okay.
Just to sort of get away from that whole thought process.
Okay.
The trick, though, prescription drugs in general, it's, yes, we're treating maybe the teenager for some injury that they have, a sports injury, but we have just as many, if not more, parents that have had bad backs and, have those bottles just hanging out that are easy to access. It's easy to try it. It's a night of partying and grab a couple beers and take somebody's Percocet, we're off.
Exactly.
Those are the areas that are incredibly dangerous. Just can't have that.
Okay. So I guess we want to look at, what do we got? Wrapping up here in a minute here? Okay. So we've got about a minute left here. So let me just ask you, as a Chief of Emergency Medicine here at Signature Healthcare Brockton Hospital, what would you say to the parents who are out there listening to this program tonight in relationship to if they're dealing with a loved one who may be an addict?
So a little broader even would be, if you have a loved one, they might be an addict, you might not know. Always consider that. The drugs are everywhere, very common. If you have someone in your family that is an addict, it's you just have to keep trying. We're trying to give every opportunity to make the intervention that's going to work. Do they work? No. The vast majority do not work. But you have to give every chance over and over and over again, and it's amazing what families try and go through. It's incredibly frustrating. Sometimes you have great success, sometimes you don't. But it's family. You just have to keep trying at that. So you have to go out and seek and get help on this one. There's a lot of resources out there. You got to bring them all to bear.
I do think that is part of the key, is that there are a lot of resources out there, and as a family member, it's a fine line between what you think is helping the addict versus enabling the addict.
Exactly.
and as when you were emotionally part of that family, it's a difficult line to recognize.
Right. I believe that.
Drawn in the sand. So I think we are here at the end of our program. Dr. Lawson, I want to thank you very much for coming in and sharing with us what happens in the emergency room. And on behalf of all of us here at A Deadly Silence, we'll see you again in our next episode. Thank you.